I
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ألم نشرح لك صدرك ووضعنا عنك وزرك الذي أنقض ظهرك ورفعنا لك ذكرك فإن مع العسر يسرا إن مع العسر يسرا فإذا فرغت فانصب وإلى ربك فارغب صدق الله العظيم.
Sadi, welcome everyone. This Citywide Cath conference is part of the series which we started a few months ago. It has been a resounding success all over Pakistan. Other cities are following suit, like Lahore, like Peshawar, Islamabad, Multan, etc. And the credit goes to a rejuvenated Pakistan Society of Interventional Cardiology, Pakistan Society of Interventional Cardiology, and until a few years ago was basically a dud, DUD. But then people like, I forgot all the names, but including Dr. Bashir and he was sitting here, Dr. Tariq Ashraf, they renewed life into PSIC. And now it's a robust society. Not only is it doing a lot of academic teaching, but it's also part of Pakistani legislation about, intervention. So I think the two gentlemen here, they deserve. Dr. Bashir has also started Cath registry called CROP, Cardiac Registry of Pakistan, and it's going quite well. And hopefully, in a year or two, it'll start yielding results. And Dr. Tariq Ashraf has launched the Journal of Pakistan Pakistan Society of Interventional Cardiology. And I think it's going to get international recognition very soon. It already has to some extent. So, sahi bande ko sahi jagah rakhein to there's always progress. There's always. Before we move on, before I invite people onto the stage, Pakistan Live is going to happen in August. Okay? So we'll ask Dr. Bashir to talk about it after we present the cases. So we would like all of you to be complete and willing participants in Pakistan Live. Okay? Because the success of these kind of events, it reflects on our country. We are a much bigger, much more talented, much better country than a lot of our neighbors, but we're light years behind them just because we don't believe in meritocracy. We don't believe in helping each other. We don't believe in being united. And the only way to alleviate all of these things is to stop pulling each other's legs, to be united, to believe in meritocracy. Okay? So without further ado, can I ask the first panel of, one of the panel, the first expert, Dr. Abdul Baki, consultant, Akhan University Hospital, to please come and join us. Can I ask Dr. Nawaz Lashari, who is chairman of cardiology, Civil Hospital, to please come on stage? And I also asked Dr. Ghulam Abbas Sheikh, who's a consultant cardiologist in Civil Hospital, to grace us with his presence. गुलाम बादशाह को बहुत दफा मैंने कहा है कि अपनी एब्रीविएशन चेंज कर लें नाम की, क्योंकि जैसे तब्बा में लिखा होता है BA बशीर हनीफ, मेरा लिखा होता है FA, तो गुलाम बादशाह का क्या बना? चलें। Can I ask Dr. Tariq Ashraf to please come onto the stage? Dr. Tariq Ashraf is representing Karachi Institute of Heart Disease. And can I please ask Dr. Bashir Hanif, who is Medical Director of the Heart Institute, to please come on. Can I ask Dr. Wakar to present the first case? Dr. Wakar is a cardiology fellow. So this time, in previous CAS conferences, what we used to do was we had a fixed panel of experts, but because we have a lot of cases, so we'd be mixing the experts after every. So can I also ask Dr. Javed Sial to please come onto the stage? वो भी जरा दे दीजिएगा. As always, what we'll be doing is we'll be discussing the case, and the panel would rate the presentation given by the presenter. There'll be 5 categories, and they'll rate the presentation according to the presenter out of 10. Each category would be 10 marks. So we'd be rating them out of 50. And the top presenters would be given a special memento at the end of the presentation. So without further ado, can I ask Dr. Bakar to please start his presentation?
Assalamu alaikum. My name is Dr. Syed Bakar Ahmed. I am an intervention cardiology fellow at the Aga Khan University Hospital. So I'm quite excited to be presenting an interesting case that happened in our hospital recently. It's more of a Cath case. So it's a bit difficult to see from there. All right. So this is a 64-year-old male that presented in the ER with complaints of 2 episodes of crushing chest pain for the past 6 hours, and he has had associated shortness of breath. His relevant history is that he had hypertension, and very importantly that he had kyphoscoliosis secondary to Pons disease since 1972. And he also had restless leg syndrome. He had a very difficult time keeping his legs together and involuntary movements, or he had the urge to have movements for the legs. Because of his kyphoscoliosis, he had restricted lung disease, and he had been in follow-ups with the pulmonologist quite long. And he had chronic backache, and for that he was on long-term NSAID use. And he had pulmonary TB since 1972. That was also one of the causes of his lung diseases. He presented with this ECG. You can see that there are ST depressions from V4 to V6, and then some questionable ST elevation in V2 to V3. Right, so we gave him antiplatelets, anticoagulation, repeated his ECG. His chest pain was relieved. This was the ECG. You can see deep T wave inversions from V1 to V4, and still the ST depressions from V5 to V6. So, well, he had a drop leak. His TIMI was poor. So early invasive strategy. Other issues were pulmonary edema, and very relevant that he had kyphoscoliosis and restless leg syndrome. He had a very difficult time to lie flat for long periods of time. So we had to keep him his head side elevated. since this is just diagrammatic representation of kyphoscoliosis, a refresher. You can see that the spine is quite tilted towards one side. The rib cage is quite distorted, very distorted anatomy. So considering his situation, the kyphoscoliosis, the restless leg, unable to lie down flat, we thought of going for a radial approach as a better option than a femoral approach. But as soon as we started the radial, we could see that well, it's not going to be an easy one. There was a very big loop from the right side in the subclavian and in the aorta, and the aorta was quite compressed. He had a very short ascending aorta. We switched the Tiger 5 French to an EBU 3/6 French, and well, from the right side, we were unable to engage the left coronary artery. However, we engaged the right from the Tiger catheter, and you can see it's a non-dominant vessel, no significant disease over there. Well, the challenging part of the case was getting the left side engaged. And well, now we're contemplating on whether going to the femoral approach or the left radial approach. Now, after quite discussion, we took the left radial approach. The reason being, we did not want the patient to have a femoral sheath in place for quite long. It was very difficult for him to have a femoral sheath in place for long and lying down for long periods. However, this was not an easy task. We had, with some expert manipulation, we did find the left coronary artery and we were able to engage it. So, not sure where it's so the caudal views, just to go back, one of the slides isn't working. Well, as you can see, the circumflex is fine. There's some disease in the diagonal, around 60-70% disease in the diagonal. And on the cranial shots, you can see that the LAD is diseased. You can see around 80-90% stenosis in the prox LAD, which is extending up to the ostia. The allocranials, we took some good allocranials over here. So the important point was that it was a difficult engagement. However, we got the EBU catheter engaged from the left side. We saved the patient from a long durations of lying down flat. We started the PCI, we wired the D1 and the LED with a BMW wire. But this is again, we are here for learning from each other. After again, from my own mistakes, we have learned the hard way also. So if you try to avoid this non-dominant honestly to get on that long, especially in the mentioned I'm sure probably how we focus system will have or translator and around existing non-dominant guy is just 54 hours long and to be on. We give you that is important. You really don't want to fix everything over there. जी sir. Sorry. Right. जी sir. मैं किससे करूँगा फिर?
केस खत्म करेंगे हाँ नहीं वो आपको हाँ वो
Sir, thank you for the valuable comment. The trainee resident got the same feedback from us. So we wired the LED and the D1 with BMW wire, and then you can see that we started off with the POBA to the diagonal with the semi-compliant balloon. The results were fine, no dissection or any other complications. You can see that then we started with the pre-dilation of the LED lesion with the semi-compliant balloon to 15 at 8 atmosphere. The results, we were happy with the result after the ballooning. And next thing, we put in a Zines expedition 2.5 into 48 mm and deployed it at 12 atmosphere. We covered it from the ostia to the mid. And this is the result after the stenting. We were happy with the result. We जी सर वहाँ पर है अच्छा 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 ठीक ठीक है so this is the result after the stenting and we post-dilated with an NC balloon 2.5 into 12 up to 26 atmosphere, and then a pot was done with a non-compliant balloon of 30 into 8 at up to 3 atmosphere. This is the final result. We were happy with the final result. There was TME3 flow. There were no complications. And so this is just a refresher that the aortic angulations are very difficult in patients that have kyphoscoliosis with POTS deformity. This is a recent paper that I came across. It was in April 2022. So as you can see over here, this is probably what we were facing. The take-home points: coronary angiogram and PCI in patients with kyphoscoliosis is technically challenging because of the distorted anatomy. Patients are unable to maintain supine position for too long. So need to anticipate that these patients may not be a good candidate for intubation or cabbage later on. And well, the other point was left radial axis is a viable alternate to switching to femoral approach. So most of us, many of us do have that tendency to go into femoral approach directly without probing the left radial. So that is one point. I do have another small second case if
We don't have the hearing parts.
we don't have that. Yeah.
Second thing is, again, अगर आपको दिखाए ना, diagonal आप क्या पहले, what was the logic of doing that?
We thought at that time the diagonal was significant and had a larger area of right. We took out the jail wire at the end. Before so well, we do have a wire inside the diagonal at the time of stenting, and then after stenting.
जो बेसिक्स है
Yeah,
ये
this
जब
is
आप
the this is the
साइड ब्रांच को जब आप balloon करते हैं really this practice do when we do two strand strategy and properly with bifurcation. लेकिन usually आप पहले diagonal को अगर if you are going to balloon diagonal there are fair chances that might be dissected.
agreed. We did have a jail wire over here, but after the
Yeah, I think there are two things. I'm sorry to tell you. Basically, the reason I think ostium diagonal का ostium इतना affected नहीं है. If you go back, actually proximal diagonal है. पहली बात तो ये है. So I wouldn't be worried about really कि validity के stand से जो है it's going to be pinched या कोई problem होगा. Ostium में अगर disease है more than 50% or 60%, then I would be more concerned. लेकिन मेरा ये डेफिनेटली मेजर कंसर्न है. एक दफा अगर आपने बलून ये जो 60-70 या बॉर्डर लाइन 50-60 मॉडरेट रीजन है, अगर आप इसको छोड़ देंगे शायद अगले 3 साल बाद तक भी ऐसा रहे. लेकिन एक दफा बलून कर दिया तो यू नो व्हाट इज द रीस्टोसिस रिस्क आफ्टर बलून. So it's like almost 20-30%. So now जो है you are putting that patient into another risk. अच्छा दूसरा luckily that section नहीं है क्योंकि 2O का balloon use किया गया है. And this vessel is definitely not 2O. This is almost 3O, same size as diagonal. So reality and उसके branches भी निकल रही हैं. So that's why लेकिन ये है कि अगर आप यहाँ पे हो वहाँ पे 3O से या बड़े balloon से करते हैं तो you could might have ended up वो एक काफी बड़ी ब्रांच वहां से निकल रही है, उसमें भी जो है वो प्रॉब्लम हो सकता था. तो आई वुड अगेन आई थिंक ड्यूरिंग एक सबक आज याद रखें कि ड्यूरिंग एक्यूट सेटिंग ट्राई टू डू एज मिनिमम एज पॉसिबल बिकॉज पेशेंट कैन रियली ऑलरेडी लाइक ये पल्मोनरी एडिमा में है, वेरी डिफिकल्ट केस है, इतनी मुश्किल हुई आपको ले जाने में, गॉड फॉरबिड ये अनस्टेबल हो जाता है, आपको बलून पंप डालना पड़ जाता है. तो दैट्स गोइंग टू बी अनदर डिजास्टर के पे मोरल से जाके आप किस तरह ये चीजें करेंगे. So इसमें जो है मेरी पर्सनली एज मिनिमम एज पॉसिबल. सिमिलरली स्टेंट की भी आई नो कि हमारा है कि जी नॉर्मल टू नॉर्मल इनिशियली वो करना चाहिए, बट दैट अगेन आई फॉर माई सेल्फ आई अप्लाई दैट इन इलेक्टिव सेटिंग एंड एक्यूट सेटिंग में अगेन स्पेशली इफ आई एम थिंकिंग जी अनस्टेबल फ्लैग है, उसमें मतलब ये है कि जितना शॉर्टर स्टेंट हो जो कि डीएन को कवर कर रहा हो, that's what I do. Again, the longer you use, the risk of no reflow और वो सारी चीजें होने के चांसेस जो है वो बढ़ जाते हैं. और स्पेशली यहाँ पे तो I don't know मतलब इसको आप प्ले कर रहे हैं स्पाइडर व्यू में तो proximality में ठीक है फ्लैग था but it wasn't really that bad. और I would have probably not come back again. हर एक की अपनी personal, I'm not criticizing, but
Sure. We did not want to land up in one of the plaques, and so we wanted to cover everything. That's true.
Besides this, I think proximal LED, what's our practice, but usually we put 3.5 at least. Yeah, come से कम भी 3.
He was a very short person and very
Though this
That's
case
why we
was-
went for a pot with a 3 later on.
though this case was very nicely done, there's no doubt about it. It was a difficult situation and it was handled properly, but that's my comment that proximal LED usually that's absolute contraindication in NICD that you won't put stand below 3 mm.
So our sizing was, but obviously sizing is done with the distal vessel. So we thought the distal vessel was not 3/0 and so 2.5 would have been the safer option. That's why.
It's been a discussion.
If you have this alien and like choose the larger size stand where now with your access. The thing is that you have find it people when you stand piece size of the size of the still segment of the you see the still segment is not open plan. So we and there's enough space from when wrapping with all the segment doesn't start from the skin below that. So you do the bigger stand and then you can increase it to the 3.5 mm. और एक चीज बहुत याद रखनी कि lot of times diffuse series होती है आपको आइडिया नहीं होता कि वैसे का साइज छोटा लगता है but remember आपको डिस्ट्रीब्यूशन देखनी है अब ये एलईडी जो है इतनी बड़ी है कि ऑलमोस्ट रैप अराउंड है और नीचे की भी अच्छा खासा बड़ा साइज है डायमीटर भी इतनी बड़ी निकल रही है that gives you some idea that it has to be a bigger size not like एक चीज ये है कि आप जितना लंबा स्टैंड कर सकते हैं आईएसटी का ठीक है लेकिन when you're doing this in the cube state after taking decisions on your feet some of them may be perfect some of them may not be the result is very good लेकिन एक चीज और suppose after dilating the diagonal after the areas of again now we have to put two stands so आपने दिया था access radial से 7.8 push के लिए डाल सकते हैं आप अगर इसमें 2 stand strategy करनी पड़ती तो आप कौन सी करते हैं आप यहाँ आप क्या करते हैं क्यूलॉट करते हैं
Probably culotte.
आप 6 stand से तो नहीं कर सकते तो the better thing what is meant to just leave the diagonal ये तो we were lucky the diagonal is okay I think the best thing that Dr. and said in this setting for making progress and they were ever pre-diagonal transfer other thing is that अब तो डेटा भी आ गई है कि जो डायगोनल में अगर आप जेल डायगोनल में 70% डिजीज है तब ये तरह का ब्रेकअप भी नेगेटिव 70% डिजीज पे डायगोनल पे नेगेटिव आ जाता है
I think we can go bonds. Move forward. We will move forward.
All right. Thank you, sir.
ये याद रखें कि all's well that ends well, ठीक है? Nothing succeeds like success. अच्छा रिजल्ट आया डेफिनेटली, लेकिन ये 2-3 चीजें लर्निंग के पॉइंट ऑफ व्यू से जब आप जा रहे हो तो ये आप ज़हन में रखें, ठीक है? एक हमारे बुजुर्ग कहा करते थे, better is the enemy of good. You get a good result, you come out. Okay, never go for better. ठीक है? So well done, Vakar. Now, can I ask the presenter from Dow University Hospital? This is a case done by Dr. Numan Kakeporto. He's the second interventional cardiologist that was trained in Liaquat National Hospital. So, Dr. Mishal is going to present the case. Thank you.
Assalamu alaikum, everyone. My name is Dr. Mishal Zera, and I'm working as a cardiology resident. Today, we are going to discuss a case of a 70-year-old female patient. She's a known hypertensive, which was uncontrolled on medications, and she's a known case of asthma, and presented to ER with a complaint of typical chest pain for last 1 hour. Patient had similar episodes since last 3 to 4 months, which aggravated on minimal exertion and were relieved with rest. Patient was started on anti-ischemic therapy 1 month ago, but it resulted in minimal symptomatic improvement. When the patient presented to us in the emergency department, she had anterolateral ST segment depressions. Her troponin was done, which was negative, and echo showed a normal biventricular function with no regional wall motion abnormalities. Patient was managed as a case of unstable angina. Her TIMI risk score was 4, and coronary angiography was planned for the patient. So, okay, so this is the first view showing the, can you please read it again? Okay, so in this LO view, we can see the right coronary system is engaged with the TIC catheter, and there's a severe tubular lesion in the mid RCA. So in the cranial view, we can see and appreciate the lesion at the origin of the right PLV. This is the angiogram of the left system showing a severe discrete lesion in OM2 and disease in the proximal LAD. Can you kindly please play it one more time? Thank you. So again, in the caudal view, we can appreciate the lesions in the OM2 and the proximal LAD. So in the cranial view, we can see the severe diffuse disease in the proximal to mid LAD. This is the RO cranial view. So on the basis of the coronary angiogram, the syntax score was calculated, which came out to be 20, and the syntax score to favored CABG with 3.4% mortality for 4 years for CABG as compared to PCI, which was 7.7%. Cardiac surgery team was taken on board. Patient and family were counseled in detail regarding the risks and benefits of both the procedures. They refused for CABG and opted for multi-vessel PCI. Sorry, sir. Sorry, sir. Sir. Play again. Okay. So we proceeded on to the revascularization of RCA. We took the GR4 6-French catheter and used the coronary PI50 wire to cross the lesion. It was parked in the distal RCA, and the lesion was pre-dilated with SC 2.515 balloon. We took a resolute integrity 3.534 mm stent. However, when we tried to inflate the stent, there was dislodgement. The stent did not expand from the mid segment, however, slightly was expanded from the proximal and the distal segment. We tried to expand the stent at high pressures, but we were unsuccessful. Our patient started becoming symptomatic. She became bradycardic, hypotensive, and was experiencing severe chest pain. There were ST depressions as in the ECG. Now, as our patient was very symptomatic, we decided to retrieve the entire system in block. So this is the angiogram showing the retrieval of the system. Thankfully, we retrieved the system in block. However, the stent was left in the radial artery just above the styloid process, just above the puncture site. So as our patient was very symptomatic, we put the TR band at the radial axis side and we gained the femoral axis. So just before we move on to the next angiogram, I would like to say that unfortunately we could not save the shots, but from that moment. So when we regained the axis, the femoral axis, and we engaged the right coronary system, there was a dissection of the right coronary artery and there was no flow beyond that. So we took a coronary PI50 wire and we were unable to cross beyond that. So we presumed that this is a false lumen, and we took another coronary PI50 wire to cross the true lumen. So we were successful in doing that, and we pre-dilated the lesion. We took out the first wire, and this is the shot after we had restored the flow to the right coronary artery. So we took a resolute integrity 3.538 mm stent, and we successfully deployed the stent with the good TIMI3 result achieved. TIMI3 flow achieved. Right. So this is the post-dilation of the stent, and a good TIMI3 flow achieved to the distal RC. Sir, sorry, sir. So post dilation was 3.5, 2.5.
So क्या reason हो सकता है?
Sorry, that's 3.5. Yes.
तो क्या reason हो सकता है?
सर बलून उसको स्टैंड में जैसे ही हम डिप्लॉय कर रहे थे तो वो इंफ्लेट नहीं हो रहा था, लेकिन हाई प्रेशर पे भी वो जो है वो ओपन नहीं हो रहा। जब बलून को बाहर खींचा तो बलून भी स्टक हो गया था, बाहर नहीं आ रहा। तो फिर हमने थोड़ा सा पूरे सिस्टम को पीछे खींचा तो हमने देखा कि बलून के साथ स्टैंड भी पीछे आ रहा है। तो हमने उसी वक्त पूरा ऑल वे पूरा
Problem seems to be manufacturing or something else because कि बाद में तो वो lesion इतना it was not tight lesion के
So
and
rectally it didn't take-
sometimes there are problem in preparing the stand, you know, people क्या करते हैं कि वो गलती में उसको बलून की तरह जो सेकंड ऑपरेटर होता है वो उसको नेगेटिव कर देता है और इस तरह से स्टैंड की पोजीशन
देखें
आउटसाइड
ये मैं आपको बताऊं, दिस इज प्योरली ए टेक्निकल प्रॉब्लम, ठीक है ना। देयर इज नो वे दैट न्यू इंटेग्रिटी बलून विल हैव दिस काइंड ऑफ अ प्रॉब्लम। इवन आपने देखा कि चलो मिड वाला पोर्शन तो इट वाजंट इन्फ्लेटिंग, बट इवन प्रॉक्सिमल एंड डिस्टल पोर्शन भी थोड़ा सा इन्फ्लेट हुआ हुआ है। तो दैट मीन आइदर देयर इज ए प्रॉब्लम विद योर इंडिफ्लेटर, ओके। सो व्हाट आई वुड हैव डन इज कि मैं उसको रिमूव करके आप डायरेक्ट जो है सिरिंज लेके उससे आप पुल करें और दूसरा इंडिफ्लेटर लेके ट्राई करें। आई वुड नेवर हैव पुल्ड दिस लाइक दिस, ठीक है ना, बिकॉज दिस इज ए प्योर डिजास्टर बाय पुलिंग दिस once you have inflated the stent. This is like you are lucky that you are able to the patient saved, but this could have been it. And right coronary artery, I always tell my fellows, always treat right with respect, because it can really आपको बाकी सारा कुछ normal हो, patient can go like this. तो इसमें जो है ये डेफिनेटली टेक्निकल प्रॉब्लम है और आपको इंडिकेटर चेंज करना चाहिए था और उसका जो है आपने बीच में स्टॉप वर्क लगाया हुआ है उसको चेंज करना चाहिए था। डायरेक्ट अटैच पॉसिबल नहीं है, आपने अटैच सही नहीं होगा या उसका जो भी है कुछ ना कुछ गड़बड़ हुई है, वरना देयर इज नो वे। मतलब आई डोंट थिंक हम सब इतने बैठे हुए हैं, मतलब आई डोंट थिंक एनीवन हैज सीन दैट आज तक खास करके अंडर एंडर्स के लिए वो स्टैंड कोई आपने बहुत ही पुराना या बी या जो भी है वो किया हो, वरना देयर इज नो रीजन। मतलब
I think this complication was very well taken and ultimately the life of patient has been saved. But this kind of complication or equipment failure we usually face in cath lab on daily basis. तो वहां जब हम होते हैं तो इस तरह की सिचुएशन में डॉक्टर बशीर सही कह रहे हैं, कभी कभी वो चीजें काम नहीं करती। तो why probably from this case what I understood that you ultimately you become frustrated and you pull out all things because patient become very symptomatic.
देखिए मैं
तो
एक
इस तरह की चीजें होती हैं।
एक चीज यहाँ पे कहना चाहूंगा जो हम लोग अक्सर जो है वो नहीं करते। कभी भी इस तरह की प्रॉब्लम में आप रन करते हैं ना, नेवर एवर हेजिटेट टू कॉल योर कलीग, ठीक है ना। चाहे वो हॉस्पिटल में अगर मौजूद है तो उसको बुला लें, अगर नहीं है तो टॉक टू समबडी प्लीज। मतलब मैं डजंट मैटर कितना सीनियर हूँ, आई कॉल माय जूनियर्स। अगर मैं किसी प्रॉब्लम में फंस रहा हूँ मुझे नहीं पता, आई नेवर हेजिटेट। सलमान भी यहाँ पे बैठा हुआ हमारे वहाँ पे है फेलो, आई कॉल जिनको मैंने ट्रेन किया उनको कॉल करता हूँ कि आपके पास दे माइट हैव सम डिफरेंट आइडिया फॉर यू। तो ये हम लोग अक्सर समझते हैं कि हमने किसी को बुलाया तो शायद हमारे ही उसमें आना का मसला हो जाएगा। ऐसी सिचुएशन है पेशेंट शुड बी द फर्स्ट प्रायोरिटी, आना का मसला नहीं होना चाहिए। जो भी अवेलेबल कोलीग है आप उससे बात करें, नहीं है आप टेल योर नर्स के जी फलां किसी का भी नंबर आपके पास है फोन कॉल करें जी कि ये मेरे पास था। आजकल तो बड़ा इजी, आपने पिक्चर ली फौरन उसको व्हाट्सएप पे भेज दी कि मसला हो रहा है, व्हाट वुड यू सजेस्ट, क्या हो सकता है। आई नो कि पेशेंट को पेन शुरू हो गया था, यू नीडेड टू एक्ट क्विकली। While you are working, somebody can I know, but while you are working, you can do those things. But obviously, when this happens, but please, ये चीज एक याद रखें कि never hesitate to call anyone for help when there is a problem. इसमें बिल्कुल किसी किस्म की शर्म की बात नहीं है और ना ही इसको प्लीज आना का मतलब ना है। वहाँ पे पेशेंट को आपने सेव करना है and that should be the priority.
Did you try to stand another device? Right. दूसरे device आपने value तो सीधे क्या होगा? ये आपकी तो आपके पास पहला inflation device था, उसमें you disconnect that, and then फिर another inflation device को deflate करने की कोशिश की, लेकिन वो deflate नहीं हो रहा।
देखें आप लोग all of us are almost all of us are doctors है. आप में से किसी ने सुना है कि ब्रूफन की वजह से किसी को ब्रेन डेथ हो गई हो? I saw this one case in the UK. 16 साल की लड़की थी, उसने उसको ब्रूफिन दी उसके जीपी ने for migraine. She had a reaction probably one of its kind in the world, or 1 out of 10 million. उसको ब्रेन डेथ हो गई. मतलब ब्रेन डेथ कह रहा हूँ, उसको ब्रेन डैमेज हो गई, severe brain damage. She was on ventilator for a while, then she was weaned off, but she could never have a normal life. तो कंपनी बहुत अच्छी मेट्रॉनिक, ठीक है, और ये स्टैंड भी बहुत अच्छा, बहुत यूज होता है. ये तो पानी की तरह यूज होता है ना CBD, but nothing is perfect. 1 out of 10 million stent could malfunction. क्योंकि I know this gentleman very well. There is no way that he would not have done everything possible. और जो CD दी थी आपने, उसमें बाकायदा मैंने देखा है, you went through the other side, you took another guide catheter and you took a wire through that catheter and you punctured that. I don't know why you are not mentioning this.
Sir, I did mention.
You actually punctured that balloon, and the balloon came down, and then you tried to pull it back. So ठीक है, ज़्यादा I'm sure the जो हम जब intervention कर रहे होते हैं, stent खुलाना ले जाना is not difficult. It's a troubleshooting which is, well, or I'm sure Naman must have done all the troubleshooting possible. Technical problems, 1 in 10 million, 100 million हो सकता है बिल्कुल. और अगर जो करने वाला है वो कह रहे हैं, तो I think we should take his word for it,
प्रॉब्लम ये थी कि दोबारा जैसे पास किया कि
अगर ये जिंजो स्टेंट होता चाइना का बना हुआ, सब कहते हो ये चाइना का बना हुआ भाई, ले चूंकि नहीं उस पंक्चर किया है, लेकिन मैं एक चीज आजकल की मुनासिबत से एक और चीज मैं कहना चाहूंगा कि अमेरिकन सुपर पावर हैं, बहुत अच्छे हैं, लेकिन इंसान है, गलती हो सकती है उनसे भी.
There is no doubt कि यहाँ पे हम आके डिस्कस करते हैं और सीखते हैं. डॉक्टर बशीर अनीफ की पॉइंट बहुत वैलिड है, और इस तरह से हमने, बिकॉज वी आर वर्किंग इन अ टीम इन एन ICVD, तो हम काफी चीजें करते हैं. और टेक होम मैसेज इस केस में यही है कि बाकी लोगों को इन्वॉल्व किया जाए. बट डेफिनेटली आई रियली अप्रिशिएट द करेज ऑफ डॉक्टर, उन्होंने ये केस दिखाया एंड अल्टीमेटली थिंग्स वेंट वेल. थैंक यू.
दूसरी चीज ये है,
सर इसको मैंने दिया यार ज्यादा पानी करेगा, अगर ये हीट नहीं करता है, बार-बार हीट करता है, तो फिर हम
इसमें मैं एक चीज बताऊं, बिकॉज वी पब्लिश्ड अ केस सीरीज ऑफ डिस्ट्रॉयड स्टेंट JPA में कोई 15 साल पहले, 20 साल पहले, 15 साल व्हेन आई वाज फेलो. तो उसमें जो सर्च ऑफ लिटरेचर की, तो मेजॉरिटी इशू तब होता है जब आर्च से क्रॉस कर रहा हो. अगर ब्रेन में नहीं गया और पेरिफेरल सर्कुलेशन में गया है, तो मेजॉरिटी ऑफ पीपल से कि आप उसको छोड़ दें वहीं पे.
which means better than job यहाँ से उसको निकाल दें अगर आपने निकाला तो आप पूरी इसको रिस्पॉन्स करेंगे नहीं मिलेगा अगर आपने इसको करना है बाहर करना आपको बोल है तो नॉर्मली वे यू कैन डू इट रोटा में रखिए आप लेयर ले जाते हो पकड़ के पूरे को अनरेवल करते हुए उसको करना तो दैट विल कम इनसाइड द गाइड लगे कि बाहर करके आप उसको नहीं निकाल सकते तो वो आपकी काफी बड़ी वो करते हैं पता नहीं ये पार्टिकली इंटीग्रेटेड था गाइड तो ये लेवल पे जाके लेवल से आप उसको करेंगे तो ऑटोमेटिकली वो अपना
नुमान आपको दो चीजें देखनी है, ब्रेकियल में है कि रेडियल में आ गया है। रेडियल में आप you can leave it there. उसको वहीं डिप्लॉय कर दे।
लेकिन यहाँ से अगर वो प्रमोट हो गया और ये नहीं होगा लेकिन ये जगह ऐसी है कि वो मतलब अच्छा कर रहे हैं ब्रेन हुआ या बड़ा हुआ तो अच्छा कर देता है हमारे जब भी रिलीज करते हैं तो बाहर जाती है मसला और दैट समझ
डुअल सप्लाई है ना, अगर रेडियल में यू कैन लीव इट, नो प्रॉब्लम्स। मैं बस ये चाहूंगा सबको कि काके ये जो नहीं रेडियल अगर थ्रोम्बोज हो जाती है, डजंट मेक एनी डिफरेंस। ये है कि उन्हें एवी फिस्टुला नहीं बन सकेगा उनका राइट साइड पे। बस काके पोटो का मतलब होता है सली सिंधी में ईमानदार और सच बोलने वाला। माशाल्लाह। नहीं ये कुरान हाँ ये I think I'll give him the benefit of the doubt. This was probably a technical thing. Well done. अगले जो प्रेजेंटर हैं उनका बहुत अच्छा नाम है, परफेक्ट नेम। मैं चाहूंगा आप सबके बच्चे हों तो उनका ये नाम रखिए, ठीक है? तो डॉक्टर फैसल अहमद आए जी।
Bismillahirrahmanirrahim. My name is Dr. Faisal Ahmed, and today we will be discussing a case in which we had few complications that once happened that a nightmare for our intervention cardiologist to deal with. So, a 78-year-old female patient, known case of diabetic and hypertensive, and she's a known case of ischemic heart disease, and she was complaining of typical chest pain of CCS class 2 and 3 for last 3 months. She had a cabbage done 18 years back, in which Lima and 3 SCG grafts were implanted. So now this patient came us to our department with the complaint of typical chest pain of CCS class 4 for last 48 hours. So we admit this patient, give her the ACS protocol, each and everything, baseline labs were done, her top eye was sent, and her top eye came out to be 5. So we diagnosed this patient as a case of non-ST elevation MI. So this was the ECG at the presentation. You can easily see the global ST segment depression along with the elevation in the AVR and the elevation in the lead V1. So we plan for the early invasive strategy in our patient. So the baseline echo at the bedside was done, and echo shows that there was generalized global hypokinesia with the ejection fraction of 25 to 30%, and there was normal pulmonary artery pressure, and patient was having the mild to moderate MR. So this is the left heart cath of my patient. This is the first shot. As you guys can easily see, there's a severe disease in the left main, and there's some sort of mild to moderate disease in the ostial circumflex, and there's severe disease in the ostial LED. This is another shot. You can easily see that there is a severe disease, diffuse disease from proximal to mid segment, as there is no flow into the distal LED. And this was the right system. There's a total obstruction in the RCA. So we plan for the graft study of a patient, and then you can easily see the lemma to LAD was grafted and distal to the insertion, and the lemma was grafted into the diagonal one, and there was a retrograde filling of the LAD from the collaterals of the diagonal one to the LAD on the diagonal one. So so the cat is on the native three-vessel disease with a severe distal left main. Lemma was attached to the diagonal one, and LAD is partially filling from the diagonal one. And no STG graft was found on the aortogram. So this was the patient having a typical chest pain. Now, what should be done with this patient? So yeah, we did the aortogram and tried to find all the three SVGs, but were unable to find the SVGs. Okay, sir. Exactly. Exactly, sir. Thank you, sir. So now what to be done with this patient? Any comments from the audience? So there were three options: either to send this patient for a redo cabbage, or either to go for intervention, or either for the medical management. So how many of you are going to opt for the redo cabbage? Initially, patient was on the total optimized guideline medical therapy. She was on the appropriate beta blocker and all the things. In our setup, we obviously, before taking patient for the early invasive, so we give all the antiplatelets and the heparin to this patient, and we keep her on the guideline directed medical therapy. Yes, sir. Yes, sir. Sure, sure. Exactly. Exactly. So basically, she was on the dual antiplatelet, beta blockers, nitrate. Exactly. Exactly.
जब भी इस तरह का है लेकिन मैं कहूँ कि और किसी आप जो है वो देते हो एनालिसिस को जो है
So what we did in our department, we decided to go for the PCI for left main to LED. So this was the first shot as you see. So first of all, we decided to PCI to LED. We start with the Y extension method. Finally, we succeeded to cross the region with the anti-gate approach via filter FC wire. So the first one was the PT2, which is available in our intermediate support. Then we use the second wire with the filter FC. So initially we pre-dilated region with the 1.25 into 10 mm, then 1.5 into 15 mm, but there was still no flow in the LED. Then we decided to take another balloon, still no flow, so further flow in our patient, as you can see. Dystroplonia. Bullet test. So then we decided to pre-dilate to 15 at 10 atmosphere. We inflated the balloon for prolonged duration, at least for minimum of the 3 minutes, and we move from distal to the proximal segment. We did the balloon from the distal to proximal. 1.5. So this was the result after pre-dilating with the 215 balloon from distal to the proximal segment. Then we decided to put a stent in the distal part. The stent was like 2.5 into 38, and we go up to the 12 atmosphere. So this was the result after doing the distal stenting. Then we put another stent of 340 at 12 atmosphere from mid to proximal segment. The 340 and distally. So we are having the stand of the ECHO create. That's time. So now what happened in this case? So mostly when we put a proximal stand, we used to overlap the balloon of the with the tool. Exactly. At that time, this happens. What is the classification and what is the grading of this curve? So this is the LS classification for coronary perforation. The type 1, as you all know, is external catheter. Type 2 is we have a pericardial or myocardial blush, but the orifice should be less than 1 mm. And the type 3, there is a clear contrast extravasation into the pericardium through the orifice of approximately or more than 1 mm in diameter. And type 4 should be into the cavity. So exactly. So yes, sir.
mortality is like for 100%, 20%, communicate is not 50%. It must be. Communication is 10%.
So we had a type 3 perforation. We immediately inflate the balloon. We took the NC balloon of 3.5 into 10, and we subsequently did it for. So वो shot हमने इसमें save नहीं किया, ये उसके बाद का है. हाँ.
ये तो खत्म हो
ये इसके बाद का है सर वो.
गया। आप इसलिए किया।
Exactly. Exactly. Exactly, sir. Exactly, sir. And we thought for the same thing. We only inflated the balloon, and for at least for subsequently for 2 to 3 times for approximately for the 15 minutes. At that time, we planned to reverse the anticoagulation, but we didn't reverse the anticoagulation because patient was having the chest pain, and the ECG at that time shows the ST elevation. So then we decided to proceed further. So should we proceed further in this case, or should we abort the procedure? Exactly. We didn't. Exactly. We didn't. Exactly, sir. So. So, sir, we did the same thing. We did a prolonged inflation. We didn't reverse with the protamine. We didn't do anything. We just wait and watch. So, what do you think? Should we, as you see, that we had a plan to put a stent in the left main also. So, should we proceed this procedure or should we abort? So, we decided to proceed the procedure. No, no, sir. We don't have a stent.
Otherwise, you not getting any higher. But that's where you can save the life. And again, I'm not pointing at anyone, but civil matter of the department, you will forget. Job after day, you know, you're
Exactly. Yes, sir.
And with this kind of patient, we have already some kind of आपकी बात ही नहीं
सर जो ECG चेंजेस लग रही थी वो एलईडी में सिग्निफाई कर रही थी कि क्यों हो सकता है This case was done about 6 months ago. She came to me for third time and she is mobilized. She is well oriented time placement.
So we did this standing into the left main. So as you can see now, what happened at this time? There is something another happened in our patient, and she again started to complain of the chest pain. So what happened? So initially we saw there was a mild to moderate lesion in the osteal circumflex. But at this time, we compromise the ostium of the circumflex. 3.5. So now we further plan to go for the provisional stent technique. In this patient, we again rewire from the left main to the circumflex and we did the kissing. So this is a small presentation of the provisional stent technique. These are the few techniques of the bifurcation we mostly use in our daily routine cases. So this was the result, and we are now doing the report with the 3.5 into 8 with the higher pressure. 4 or 5, sorry, 4.5 into 8 with the higher pressures. 4 into 8, the higher pressures. Yes, a provisional stent technique. So mostly we did the balloon to the side branch only. It's a single stent technique and balloon to the side branch. Yes, no stent, single stent technique. So this was the result. There's a good flow into the LED, and there was a good flow into the ostium of the circumflex. So at the follow-up, patient is following an OPD, and her CCS class angina has been improved from class 4 to class 2, and alhamdulillah, patient is doing well. Thank you.
Actually, कसरे नफसी से काम ले रहे हैं. This patient of Dr. Ghulam Abbas, she did Karachi marathon just a few months ago, and she was second. So very good result. We have some new people in the audience. Can we ask, and she is the executive director of Karachi Institute of Heart Disease. Can we ask Dr. Rifat to please join us on stage with, and also Dr. Tariq Farman. Please. नहीं वो आप वो नहीं लिखेंगे, लेकिन आप वैसे बैठेंगे. आ जाएं. Sir ji. Now can I ask Dr. Bashumal? नहीं आए. Okay, Dr. Khalil Ahmed Sheikh, who started with Liaquat National, and now he's mashallah a fellow in NICB.
Assalamualaikum, I am Dr. Khalil, and I'm here to present the case of dual disaster. And actually, in this case, I was scrubbed with my professor, Professor Javed Akbar Syal. So let's start this case. Actually, this is a dual disaster. My patient was 37 years, young male patient having no comorbid, presented with history of acute coronary syndrome 1 year back. And at that time, the primary PCI to left main to LAD was done successfully, and he was smoothly discharged. So let's see, you can appreciate the right coronary system looks normal, and you can see the left system. Can you play it again? Loop लगाया हुआ था, so you can see this is the caudal view in which left main looks significant diseased, and also osteoproximal segment of LAD. This is the cranial view in which you can appreciate that LAD is severe disease, and this one is spider view in which again you can see. Can you play again? Second one. Yeah. Ostial LAD and left main is significant disease. So at that time, the PCI from left main to LAD was done. Post dilated. This is the final result. You can see here the ostium of circumflex, which looks little bit pinched at that time, but he was smoothly discharged. Yeah. So he was smoothly discharged, and after a couple of months, he developed typical chest pain on exertion. And he came in OPD multiple times and his medical therapy was optimized, but still he had typical symptoms. So 3534, 375. Yeah.
That is fine, if people drive in the, but it's never less than 450. It's so many.
It is finite formula. You can calculate from the circumflex and LAD. Yeah. Right. Right. Right.
With these big buses on there, because this can be not and from all over that would be visible.
So he remained symptomatic despite of optimized medical therapy. So we planned to take him to cath lab for the elective angiography. So we did elective angiography at that time. You can appreciate the circumflex ostium is critical. So we plan to put another stent in the ostial circumflex. So
at this point of time, जी, नहीं, it was इसी तरह था, लेकिन over the course of 1 year, patient after 2-3 months he start complaining of chest pain. He was active, as you know, his age was less than 40 for a young patient. So he start complaining, and with time, his complaining increased. In last 6-7 months, he lost follow-up. 2-3 weeks back, he came to me and he went into different hospitals. Ultimately, they all increased the medicines. So finally, I discussed with him that we can do the tap, probably in my mind, कि हम इसको जो है extend करके एक bifurcation करें. Then I took this patient on the table. Next.
yeah, it was pinched little bit.
तो उस वक्त we were dealing ACS. जैसे डॉक्टर बशीर ने कहा, patient उस वक्त because you know left में 90% थी, patient sick था, तो we didn't take care of circumflex at that time. But that's another thought. But क्योंकि जितना केस को simple करके ACS को लिया जाए, तो that's another thought.
For me again, I have to really, when I'm doing out big vessel is more important and big vessel as a bigger area of ठीक है ना. और इतना अगर मैं ऊपर वाली होगा तो बोलने का प्रयत्न अगर नहीं करता, which is 100%, तो नीचे सर्व की डिस्ट्रीब्यूशन ना होने के बराबर है. तो मेरे लिए तो मतलब कि सर्व इतनी इम्पोर्टेंट नहीं है. अगर अगर से होगा अगर मुझे कुछ करना होगा तो अब देखिए तो रेमन जो निकल गया दैट इज मच बिगर मैसेज. और अगर मैं इसको सर्व में स्टैंड डालूंगा तो मैं आपको प्रोवाइड दैट फेमस मोर. So I may not be benefiting in that one because I'm taking distribution and the size of the reman is
ये सही है, मतलब ये that's a different thought, but I thought it a different way. Okay, you are right. I respect your decision. ठीक है, yeah, definitely. But लेकिन ultimately हुआ कुछ और ही.
So anyway, we put the wire in circumflex and LAD, and we planned to do the pre-dilation of this ostial circumflex. We did it with 215 balloon, and then we tried to put the stent in ostial circumflex, but it was not crossing, unfortunately. Then we plan to take the 215 balloon to again pre-dilate this lesion and to open up the struts. So after that, we again tried to cross the stent, but unfortunately, again, it could not cross.
So few things are पीछे वाला व्यू चलाएं एक दो. इसमें गाइडर शुरू से ही कोक्सियल नहीं था, अगर आप देखेंगे तो हाँ थोड़ा सा बाहर हो जाता है. एक चीज ये थी. Then what other thing I tried? I don't know कि वो
Then we tried to take
we guided नहीं स्टैंड पे पीछे थे. then we change the guider.
We
Cath
plan to
Case.
change the guide from EVU to L guide because of.
But
to achieve the
before that,
success.
वो view नहीं है, we use Godzilla as well के stand को, लेकिन ultimately that didn't work क्योंकि वो stand coaxial नहीं था. Godzilla अभी वहाँ काम नहीं किया. उसमें yes. उसमें भी हमने वायर की थी, लेकिन अल्टीमेटली अब इशू कुछ और शुरू हो चुके थे. नहीं, you are right. कि we were thinking कि because patient was very symptomatic कि हम उसको करें at that point of time. आगे चलें. All three branches. उसमें हमने आगे वाली जो OM2 है, इसमें वायर अगर पिछले व्यू में नोट किया हो तो हमने किया तो थोड़ा फ्लो बेहतर हुआ है. नेक्स्ट. अच्छा पीछे जाए. एट दिस पॉइंट ऑफ टाइम यहाँ पे जब हम स्टैंड ले जा रहे थे, नहीं स्टैंड नहीं गया, देन वी टुक आउट स्टैंड, तो वायर भी बाहर आ गई. तो हमने देखा तो स्टैंड तो उस पे था ही नहीं, उस पे बलून पे स्टैंड था ही नहीं, बिकॉज जाहिर है कि लॉट ऑफ प्रेशर्स और पुलिंग पुशिंग हुआ. तो देन वी स्टॉप हियर एंड हमने पूरी बॉडी को स्कैन करने लगे कि स्टैंड गया कहाँ. अल्टीमेटली वी फाउंड इट इन लेफ्ट ग्राइन.
So stand was not mounted on the balloon, so we searched out on the table and everywhere, but
दिस
at the end.
ये लेफ्ट ग्राइन में स्टैंड था जो पहले डिस्कस हो चुका है. देन वी थिंक कि चलो इसको यहीं छोड़ देते हैं, लेट्स मूव फॉरवर्ड. नेक्स्ट. चल नहीं पीछे जाएं. अच्छा एट दिस पॉइंट ऑफ टाइम वी टुक अनदर स्टैंड और अच्छा वो व्यू नहीं किया स्टैंड में, बट हियर वंस वी चले यहाँ
You can look at here, just.
I will explain. We took another stand. We tried to put it in the same way, लेकिन वो वहाँ नहीं गया और again that stand dislodged. Stand is return पे.
From the stem.
तो we checked it. We again ballooned it कि हम proper start में हैं, लेकिन फिर छोटा stand था. This time we have taken 12, 3 or 12 probably. तो वो जब नहीं जा रहा था, again there are a lot of forces. Then we found कि balloon नीचे आ गया, stand was hanging in left main in that bigger stand. अब वो पता नहीं वो view ने नहीं डाला.
Yeah, it is there. I will show.
हाँ, तो
This is BMW wire.
तो बड़ी वायर का नहीं इशू, इसमें बड़ी वायर का नहीं क्योंकि गॉडजिला तक हम लेके गए थे. एक इशू था कोएक्सियल नहीं था. देन वो जब एल ने काम नहीं किया, देन व्हाट वी डिड कि हमने XB4 लिया, गाइडर को अपग्रेड किया ताकि कोएक्सियल हो. अब इस पॉइंट ऑफ टाइम पे हमें नजर आ गया था कि स्टैंड जो दूसरा स्टैंड है वो हैंग कर रहा है लेफ्ट मेन में, एंड दैट इज थ्रू दैट वायर ऑफ सर्कमफ्लेक्स. तो फिर what I did, I took that wire out क्योंकि वो सेम तो था उसके बीच में था. Then I take that wire to this LED. Then I tried to put a smaller balloon, इसमें नजर आ रहा होगा 1.5 का, ताकि वो क्रॉस हो जाए. लेकिन वो जैसे ही हम बलून पुश करते थे वो और आगे चले जाता था. Then the typical thing which we do, I did both 2 wires and 1 torquer and across. अभी इसमें नजर आ रही है. नेक्स्ट वाला ये चला. हाँ इसमें
इधर से
नहीं जरा पॉइंटर चलाएं.
उसमें लगेगा पॉइंटर.
हाँ इसमें आपको नजर आ रहा होगा अभी स्टैंड के. हाँ नेक्स्ट.
This is the stand.
तो
Stand and stand.
देन वी प्लान कि हम पूरे सिस्टम को निकालें ताकि वो स्टैंड बाहर आ जाए. थोड़ा सा प्रेशर. नेक्स्ट प्लीज. नेक्स्ट यही करूँ. फिर हमने जब वो बाहर निकाल के
आप सब उनसे पूछे कि क्या हो रहा है.
हाँ when we took out, stand was of larger size. हम पहले देख रहे थे कि क्या हो रहा है. हमने तो 12 का दिया था, ये तो 30 का लग रहा था. तो by that time I asked my assistant professor Dr. Bashir said कि I called Dr. राजेश, वो बाहर था कि आ जाओ फौरन. तो मैंने कहा अच्छा हो गया काम, तुम जरा आप देख लो कुछ हुआ तो नहीं, ताकि हम केस को बस यहीं रुक जाएं. Then he took diagnostic JL. Chalaye? You can see there is no stent in left main. वो स्टेंट जो 1 साल पहले लगा हुआ था वो वायर के साथ तो बाहर अभी तो आप वो तो मेरा ख्याल है RCA नहीं थी जैसे आपने कहा तो here you can realize that stent उसकी पिक्चर से
Yes, yes.
अच्छा then अब ये इशू हो गया एकदम से माहौल पैनिक हो गया पेशेंट को सिम्टम्स शुरू हो गए then I came back again कि अब इसकी लेकिन that difficulty I feel wiring this lesion because इसका तो endothelium भी बाहर आ गया था stent के साथ. It was very difficult to wire this LED now और then we put 2 stent करें आगे. Next. ये BMW. Next करें. वही मैंने खाया पिया कुछ नहीं गिलास थोड़ा बारह ना सिंपल यही है नेक्स्ट फाइनल
Yes, sir. Final year, yes, sir.
patient came to me day before yesterday after probably 2-3 weeks he's doing fine but probably he was fine because he is not moving around then I allow him to do your work this you can realize this was a stent.
This is the new dislodged stent and this one is extracted stent.
Endothelium, everything. So this was really a nightmare. This case took us around 1.5 hours in the cath lab. And ultimately, what Dr. Abbas says कि वो problem वहीं पे वहीं रहा और कुछ हुआ नहीं. But that's why जी. लेकिन एक चीज my fellow told me once he completed the case. He told me कि सर जब स्टेंट बाहर आ गया था तो पहले आप सर करके फिर निकल आते तो ही वाज राइट कि वो जो आपने बात की कि अगर आप जूनियर को भी इन्वॉल्व कर दे लेकिन शायद हम तब भी ना करते बिकॉज पेशेंट अनस्टेबल हो रहा था द फर्स्ट प्रायोरिटी इन दैट पर्टिकुलर केस यू हैव टू सेव द लाइफ ऑफ द पेशेंट
Take home message. Right. Thank you. Thank you very much.
वायर आपकी हो सकता है कहीं से सोर्स पर से जाके अंदर चले जाए उससे भी मुश्किल हो जाता है उसमें ये we need to rewire go into the LED pull back and try to do that and thirdly I would say I would next time if I go I definitely would wire the vehicles because I'm telling you if you would have put a stent in there that vehicles would go down and I would also try to before doing anything I would do that on my mouth because I want to figure area I don't know what I could be
Listen, I'm over with this. Very polite.
then I would consider taking go down here and down or even sometimes we need to city जाता होगा तो इसके लिए वायर नहीं रहा तो वायर को पुल करने के लिए आने के लिए वायर को सॉफ्ट that may help you to take that advice and get that
डॉक्टर रिफत कुछ कहना चाह रही हैं जी ये डॉक्टर रिफत माइक ले लीजिए आप
सपोज अगर ये जो इसका वायर भी सारा पुल आउट हो जाता और द ल्यूमेन वाज डिस्टॉर्टेड एट मोमेंट तो व्हिच वायर वाज सुटेबल एट दैट मोमेंट टू क्रॉस द डिस्टॉर्टेड ल्यूमेन व्हिच वायर मोर सुटेबल लेकिन अगर वायर क्रॉस की हो सपोज डिस्टॉर्टेड लिगामेंट तो सर्जिकल हमें
डॉक्टर
अप्रोच
जावेद सयाल जो हैं वो BMW वायर यूज करते हैं और चलाने में BMW की लिमोजिन भी यूज करते हैं माशाल्लाह। सर जी बहुत सारे कॉलीग्स हैं जना के पुराने, उनमें से एक डॉक्टर अब्दुल समद अचकजई हैं, मेरे पुराने, आई एम अ बिग फैन ऑफ हिज। जी जी ये कैन वी डू दिस आफ्टर, दिस इज द लास्ट केस, उसके बाद आप बेशक पूछिए हमसे। तो एक वाकया मुझे बड़ा याद रहता है, मैं हमेशा सुनाता हूँ, आज भी थोड़ा सुना देते हैं। नहीं सुनाने देते, आपने पैसे नहीं दिए मुझे। तो हम एक ही वार्ड में काम करते थे, मेरे मुझसे थोड़े से सीनियर थे, कोई 1-2 महीने या 3-4 साल। तो आप समझ साहब मुझसे सीनियर थे, हम हाउस जॉब कर रहे थे, प्रोफेसर साहब थे हमारे, क्या नाम था उनका? नहीं दूसरे जो वार्ड 5 थे, नहीं सगीर हुसैन के बड़े भाई जो थे, शबीर, प्रोफेसर शबीर थे। हाँ जी, तो वो हम साथ ही थे, ये हमसे जूनियर थी डॉक्टर रिफत। तो प्रोफेसर शबीर वाज अ टिपिकल एब्सेंट माइंडेड प्रोफेसर। तो वो आए राउंड पे, तो 3 महीने बाद आए राउंड पे, एक एसाइटिस का पेशेंट था। उन्होंने कहा अब्दुल समद ये क्या है? मैंने कहा सर एसाइटिस। कहा बकवास बेटा बकवास। फिर आए, फिर उनको फोन कॉल आ गई, वापस गए, फिर फोन कॉल, फिर आए, उन्होंने कहा बेटा ये क्या है? सर एसाइटिस का। शाबाश बेटा शाबाश। एक और वाकया, सुल्तान फारूकी साहब थे, आप उनके भी उसमें थे। तो इन्होंने स्टर्नल बोन मैरो किया था एक पेशेंट का। तो उससे मैं सुल्तान फारूकी आप लोगों को नहीं पता, ही वाज अ वेरी फेमस ऑफ हिज टाइम। वो आए, उन्होंने कहा ये किसने किया है? अब्दुल समद साहब ने कहा मैंने नहीं किया, मैंने नहीं किया। मैंने कहा बेटा मैं तो खुश हो रहा था जिसने किया, अच्छा है कि कहते मैंने किया मैंने किया। ये अमर हो चुका है इनका। अच्छा जी, Achilles heel of cardiologists, bifurcation lesions, calcified lesions, are the most, the worst chronic total obstructions. अब बच्चे बताएंगे chronic total obstruction में कब intervene करते हैं, हर एक के तो नहीं करते हैं, क्या क्या चीजें हो तो आप करते हैं, बताएं बच्चे जल्दी से। इस्कीमिया बर्डन कितना हो कम से कम तो करते हैं, 15% से ज्यादा हो, लेंथ कितनी हो, 20 से ज्यादा हो तो आप कहते हैं नहीं, आप उनको जापान भेज देते हैं, कहीं और भेज देते हैं, ठीक है। और क्या क्या चीजें, आपको डिस्टल आर्टरी नजर आ रही हो, अगर ना आ रही हो तो फिर आप सोचते हो, ठीक। लेकिन what most of us do is we do antegrade CTO, and our expertise has grown significantly as you saw Dr. Ghulam Abbas Sheikh do CTO. We used to tell our patients ki ji 50% success rate, and now we tell them it's more than 80%. Okay? But in centers which are just dedicated to CTO, nothing else, this success rate can go above 95%. As far as I know, retrograde approach is very rare in Pakistan. So we saved this case for last because this is very interesting. So can I please ask Dr. Salman to present this case from Tabba Heart Institute?
Hello everyone. I'm Dr. Salman Ishaq, Interventional Cardiology Fellow at Tabba Heart. So to begin with, this case was done with Dr. Asad Pathan and Dr. Asadullah Bukti. I was scrubbed in this case with them as intervention fellow. The brief history of the case, 56 years old male, known case of diabetes. Patient had a non-STEMI 4 weeks back, and he presented to some other institution where angiogram was run, showed mild to moderate distal left main. LAD was subtotal in the mid segment. There was severe large diagonal, and RCA had osteal disease versus spasm. His EF was normal. They attempted PCI to LAD there, but they were actually unsuccessful in wiring the LAD. So, and they left the lesion with some residual dissection and they abandoned the procedure. Afterwards, patient came to our institution for opinion. Both options, CABG and PCI, were given to the patient. Patient afterwards opted for PCI, so we decided to proceed with PCI of the LAD and to assess RCA lesion further. वहां से फॉरवर्ड कर माइनस कर प्लस नेक्स्ट कर प्ले प्ले नहीं हो रही है जी जी सर थिंग्स तो क्लिक करना तो प्ले हो जाए So these are the images of right coronary artery apparent clearly non-obstructive this time. Perhaps that was a spasm when the angiogram was done. Okay. And you can see, clearly appreciate the collaterals going to the LAD. Next. So we decided to proceed with PCI to LAD. Initially decided to go anti-gradely. 7 French right radial axis was taken, and XB3 7 French guide was taken. We wired diagonal with Scion and initially tried to wire LAD, but it was unsuccessful. So we ballooned diagonal with 2.5 into 15 regular balloon and 10 to 12 atmospheres. We tried to wire LAD with different wires like Scion and Pilot 50, Scion Black, but it was unsuccessful even with microcatheter twin pass support. So we actually had a tentative plan to go retrogradely in case of unsuccessful antegrade wiring, because the patient already had a JCTO score of around 3, so which means it's a difficult antegrade wiring. So these so we took the left radial 6 French axis and tried to approach the lesion retrogradely. So we took a microcatheter caravel from the right from the RCA to the we tried initially with septal collaterals, took Scion Black wire, but there were no favorable septal collaterals. So we went on to proceed with through epicardial collaterals. We changed our wire. We took SUO wire. Septal collaterals का advantage so ये कि if it gets perforated, the usually patient tolerates it well. But if on the other hand, if epicardial collaterals get perforated, the patient may decompensate because massive effusions may develop. Relatively safe. Yeah. So within myocardium. So we took SUO wire and through epicardial collaterals, we tried to cross the LAD. So we went on to we were successful in reaching the distal cap, and then we subsequently changed to wire with Pilot 50 and were able to cross the occluded segment. And actually, I did not have this image saved in which the wire was taken into the guide. So we took Pilot 50 wire and we took into the XB3 guide, and we take our caravel microcatheter and get parked it into the XB3 guide, which was taken integrately. So later on, we exchanged the wire with the long length RG3 wire and externalized it with right radial axis. And then what we did subsequently that over that RG3 wire, we took microcatheter fine cross antegradely, and we exchanged and we wired LAD antegradely with a BMW wire and decided to proceed with the routine PCI. Since it was a complex bifurcation, so we decided to proceed upfront with 2-strand strategy. We had a plan to do DK crush here So we already dilated the diagonal earlier. So this time we pre-dilated LED with 1.5 into 20 at 14 atmospheres and 2.5 15 at 8 atmospheres. And we, there are some images missing in between, so I'll try to explain the procedure and have some important images taken with me. So we deployed 2.5 into 30 drug-eluting stent into diagonal at 10 atmospheres. And subsequently, the stent was crushed with 3.5 into 12 NC balloon at 14 atmospheres, and diagonal was rewired to proximal cells, and first kissing balloon inflation was performed with NC. जी yes. Sir, कुछ images save नहीं है actually. ये balloon नजर आ रहा है वैसे आपको देखें, balloon नजर आ रहा है रेडी के साइड पे. The city park it is right beside the stand actually. So we crushed it, and then we rewired diagonal and did the first kissing balloon inflation with NC 3.5 into 12 in LED and NC 2.75 into 12 at ND1, and we did it with both balloons were inflated at 10 atmospheres. So this was the result, and then we put in a stent in the proximal to mid LED 2.530 at 14 atmospheres, and subsequently left main to LED was stented with 3.5 into 18 drug-eluting stent at 14 atmospheres. We did pot in the proximal LED with 408 at 16 and in left main with 4.58 at 14 atmospheres. We did IVUS at this stage, and but actually I did not have IVUS CD working here, so IVUS showed well deployed stent. So apparently our PCI was going smoothly, but we had a difficult time in rewiring the diagonal second time. We tried with various wires. Cyan Black, Pilot 200, Miracle, but no wire could cross that, were able to re-enter diagonal. So apparently in these views, the stent appears straight, and there was no explanation for that difficult rewiring. So we reviewed the IVUS again, and in those IVUS images, we found that perhaps the osteomolar diagonal was not fully covered with the stent. So might be during placement, it just went a bit forward. So that is why we missed the osteomolar diag and we had difficulty in rewiring it. So actually working in LA on our review most of the time, so it was overlapping, so we could not appreciate it initially. So with the IVUS, after IVUS, we took some different views, and in one of this AP caudal view, you can clearly appreciate the osteomolar diagonal is missed. जी जी इसको किया. So at this point, how to deal with this situation since our osteomolar diagonal was missed, and because we had to do mandatory second kissing. So then actually we were able to wire it successfully with work was wiring in Scion, and we did the balloon with PTC with 2.75 into 15, and we did the final kissing with 3.5 into 12 in LED and 2.75 15 in diagonal. So this was the next image. So we are afraid that there was some residual dissection in still diagonal. So we tried to deal it with the drug-coated balloon. We did drug-coated balloon 3015 this time, and did the final kissing with drug-coated balloon 3015 in LED and 3015 in diag and NC3512 in LED. So उसके सर हमने फिर low pressure process inflate कर दिया drug-coated balloon. So we did not stand it. Yes, we could have done that, but we tried के drug-coating balloon के कैसे result रहता है. So eventually result after all successful रहा. Final result.
bifurcation on the patient of the main hospital, or that section of it, those of us that would already have.
Last slide.
But
Bas, next. बराबर
So you can leave the department and take it. Obviously, I have probably deliberate question because the single person just take no. So I would either put a other spend other person they have to go to technical user. So although cancel was the plan, it will go on that so that can लेकिन ये है कि फ्लो ठीक है कोई बहुत बड़ी ऐसी मतलब क्रॉस कनेक्टेड नहीं है देयर इज सम कनेक्शन लॉन्ग लूप करके डीसीपी करके और दैट भी बड़ा
I was low pressure inflation तो probably वो seal हो गया
एंगल डॉक्यूमेंट को आप अपना एरिया है ये अगर यहाँ पे यहाँ मतलब होता है तो
section का फोकस की मतलब यूनिटी लो है दैट सेक्शन का प्रोग्रेसिव सही है स्टैंड के अंदर तो फॉरन बॉडी प्रोग्रेस करता है दैट सेक्शन को रिकॉल हो सकती है या रिस्टोर हो सकती है बट फोकस करना है क्लियर है भाई नहीं कि परफेक्ट उसके की डायरेक्शन नहीं पॉइंट से लगवाए डायरेक्शन से आगे किसी नहीं टर्बुलेंट ज्यादा है से एक सवाल करूंगा कि जो आपने डायग्राम को बेलून किया था फर्स्ट इंटीग्रेट था उससे पहले सारे वाइज स्ट्राइक किए थे इंटीग्रेट किया डायसेक्शन के बाद बैठ के
नहीं बाय डिसेक्शन तो पहले से ही थी उसकी
इंटीग्रेट की बात कर रहे हैं
जी जी
फर्स्ट ट्राई
नहीं फर्स्ट इनिशियली ट्राई किया था देन फिर हमने डिसाइड
क्या ये तो बेटर पर उसकी की कहा जा so that ideally it should not be that sometimes it does not. So last resort and improvement is not entirely somehow I refer to that. Not that he looks in the good thing in addition. यानी आपने बिल्कुल के अंदर डायग्राम it's some right
नहीं पहले वायर ट्राई करी फिर बलून के बाद भी वायर ट्राई की बट इट वाज अनसक्सेसफुल देन वी ट्राइड
एक कोई कमेंट अगर मुझे से कह रहे हैं कि अगर डायसेक्शन फील नहीं करनी थी तो फिर तो डायरेक्ट कोई भी बलून इज इक्वली गुड अगर आपका प्लान ही था
मेरे ख्याल में they were thinking about restenosis. That's why they went with drug-eluting balloon. If they weren't thinking about restenosis, they would have used a normal balloon. क्योंकि dissection को बेहतर करना आप drug-eluting लें, non-drug-eluting लें is the same.
Yeah.
You probably wanted
Reduce
that
the
small
restenosis.
restenosis इस जगह का ना हो, इतनी मेहनत जो की है ना, यही था मेरा ख्याल।
मैंने मैं उसको एक्चुअली सॉरी मैं उसको
30 आपने 30
और रिप्रोग्राम में तो आपको बेसिकली वायर ट्रैक ग्राफ से सही जगह तो नो नीड टू वायर पड़े डोंट वांट टू अपडेट दैट कि वो बार-बार डेट कनेक्टेड टू प्रॉब्लम समस्या इंटीग्रेट हो जाएगी तो रिप्रोग्राम में टाइप करना इसका रेडिएशन का इशू यू हैव टू मोर केयरफुल अबाउट radiation protection than I just obviously you don't want to be doing it getting it again
नहीं वो कंट्रास्ट से काफी होता है बट पेशेंट का रीजन ठीक है सर
देखिए हम लोग वेरी गुड हम लोग सब इंटरवेंशनिस्ट बैठे हुए हैं यहाँ पे लेकिन एक नॉन इन्वेसिव ऑप्शन है फॉर पीपल हु आर ऑन ऑप्टिमल और यू नो गाइडलाइन मीडिएटेड medical treatment and that is reverse that is counter propulsion extracorporeal counter propulsion 80% of patients they have symptomatic benefit. It has no prognostic benefit, but in chronic coronary syndrome basically you're going for symptomatic relief.
that is for optimum or guideline directed we talk about guideline directed medical therapy of the beta blocker doctor maximum react 169 calcium channel blocker जो है वो नॉन डायरेक्ट रिलीज में ऑप्शन के मिलर डायरेक्ट नाइट्रेट्स आपने दिया हुआ है ACIR भी इससे अटैक करता है और ये ज्यादा पर जो ब्लड डिस्फंक्शन में हेल्प करते हैं then obviously other second line anti-general pulmonary हो गया या Some people use it, try garden, and that's what these things can be used. Or after maximum and day, or after pressure be down, market to better talking someday, you want to get the pressure down to literally, my goal will be 100. अभी जितना कम से कम pressure होगा तभी आप medical director, medical office, therapy का क्या होगा. और अगर फिर भी नहीं होता, then you can consider and take over ECP. ECP, different mechanisms have been proposed. Symptomatic benefit होता है, prognostic benefit नहीं है, but you have to remember that it's like 36 session or almost 100,000 भी or almost 50,000 cost of.
कोई ये नहीं कह रहा कि आप भेजें पेशेंट्स को, एंजियोप्लास्टी कराएं सब. अच्छा जी, ठीक. अच्छा जी, another mention before we, another two mentions. Dr. Bhatti Saab is doing excellent work. Sir, we appreciate the work that you're doing at your hospital. आप satellite center हैं NICVD का, है ना?
कौन सा? लेयरी
जी जी.
डॉक्टर खालिद भी
नहीं तो हाँ जी, डॉक्टर खालिद कहाँ पे हैं आजकल?
ये तो हमारे पास NICVD
अच्छा, लेकिन you're doing very good work जहाँ पे भी हैं आप. Very good.
जहाँ भी
जहाँ होते हैं वहाँ पे महफिल जमा लेते हैं, ये इनकी खासियत है. और डॉक्टर उमैर अबरार हमारे जवान स्मार्ट से डॉक्टर हैं. ही इज कंसल्टेंट एट OMI, इज डूइंग वेरी गुड वर्क, so well done उमैर. डॉक्टर उमैर का भी एक केस था, वो अनफॉर्चुनेटली हम प्रेजेंट नहीं कर सके. वो भी CTO था. So basically, this CAT conference is for teaching and learning of juniors. So what we do is we encourage the presenters as well to present the best that we can. And then we have some mementos, some gifts for them. In our view, all of them are winners, all of them. There are no winners or losers as far as this is concerned. लेकिन कुछ जो जरा बेहतर प्रेजेंट करते हैं उनकी हिम्मत अफजाई और पजीराई जरूर करनी चाहिए. आज जितने भी केसेस थे उनमें से कुछ ऐसे थे जिनमें बहुत शदीद काम पे टांग गई थी. जरूर ऐसे था, है ना? वो महसूस हो रहा था बैठ के. तो कैन आई आस्क डॉक्टर सलमान to please come on stage, and can I please ask Dr. Rifat to give him his memento for being the best presenter today. अच्छा जी, ये ऑर्डर से नहीं है, ठीक है? मतलब आपकी सबसे अच्छी थी, तो you were the best presenter, but only by 0.01 marks. बाकी जो हैं ये ऑर्डर से नहीं है. आप सब आएंगे, मोमेंटो लेते जाएंगे. जो अब नाम लूंगा doesn't mean they're second or third or whatever. So can I ask बाकियों के नाम? Can I please ask Dr. Mishal to come on stage? And can I ask Dr. Bashir Hanif to present? Thank you very much. आपकी राइटिंग डॉक्टरों वाली है. आपने जापानीज में लिखा, नहीं समझ आ गई. Can I please ask Dr. Khalil to come on stage, please? And can I ask Dr. Javed Sial to please present? Next, can I ask Dr. Waqar to get his, and can I ask Dr. Nawaz Lashari to present? And can I ask the presenter with the best name, Dr. Faisal Ahmed, to come on stage. And can I ask Dr. Tariq Ashraf to please present him with you? Ji.
I think the presentations were very good. Being an editor-in-chief of Pakistan Journal of Cardiovascular Intervention, I invite all of you to submit your presentations or case reports, especially original articles or review articles. And आप इसमें जितना आप जमा कराएंगे उतना ही फायदा होगा और जर्नल भी जो है ऊपर जाएगा. Especially one of the case जिसमें stent जो था ना वो बाहर आ गया था. Probably it was from NICVD. And I think this was, to my understanding, it was good enough with pictures. And I would suggest that they should submit the case reports in our journal. Thank you.
हमारे एक बड़ा इवेंट आ रहा है पाकिस्तान लाइव और डॉक्टर बशीर उसके वो चीफ ऑर्गेनाइजर हैं. तो प्लीज जस्ट अ फ्यू वर्ड्स ऑफ encouragement and motivation यहाँ स्टेज पे.
Thank you. I think first of all, congratulations to all who presented. And जो भी हम बात कर रहे थे, it was just a discussion for learning for everyone. किसी भी particular कोई criticism नहीं था, तो please don't take it negative. It's a positive criticism. Again, we learn every day, even at this stage. तो ये as a learning experience के तौर पर लीजिएगा, हमारी मतलब discussion या उसको negative criticism नहीं लीजिएगा. But everyone did a great job, and thank you very much for being here and presenting this. Two things I wanted to talk about. One is obviously Pakistan Live. I think all of you know, Alhamdulillah, over the last few years, it has really become an international conference, and we have faculty and people from all over the world. Society of Cardiovascular Angiography, Interventional Cardiology from USA has partnered with us. Asia Pacific Society of Interventional Cardiology has also, and similarly American College of Cardiology. So all major organizations has officially been partner after seeing what we have been doing. और alhamdulillah live cases और वो सारी चीजें तो अपनी जगह पे होती हैं. इस साल हमने 2-3 चीजें जो important की हैं, and I wanted to point out, पहले भी although के हुआ है, वो ये है कि first day जो हमारा होगा, it's going to be fellows course and nursing and technologist course. We feel कि nurses और technologists जो team है cath lab में, that is as important for me as myself. अगर कोई emergency होती है इस तरह के situation में जो हमने बात की है, उस वक्त जो nurses और technologists role play कर सकते हैं वो कोई भी नहीं कर सकता. हम focus उधर कर रहे होते हैं, but patient पे जो है वो focus वो लोग कर रहे होते हैं. And we felt कि जी उनकी इतनी ज़्यादा training नहीं होती है, and we are going to focus on that कि एक basic curriculum होगा जो उनके लिए होगा. Similarly trainees के लिए हमने same day में पूरे दिन का वो एक basic review course है, सुबह से लेके late afternoon तक चलेगा, and it's going to cover everything about basics. मैं अक्सर पहले भी एक टॉक दिया करता था, और गोल मेरा ये होता है कि जी एक वो आई थिंक हम हिपोक्रेटिक ओथ भी लेते हैं, वो कहता है कि प्राइमम नॉन नोसियर, फर्स्ट डू नो हार्म. एज ए डॉक्टर्स दैट्स आवर गोल. और आई थिंक एज इंटरनेशनल कार्डियोलॉजिस्ट दैट बिकम्स मच मोर इम्पोर्टेंट, क्योंकि आपकी जरा सी गलती जो है पेशेंट को जो है ना वो नॉर्थ पहुंचा सकती है. तो यू हैव टू बी वेरी वेरी केयरफुल कि आप क्या कर रहे हैं, और बेसिक्स आपको पता होनी चाहिए. इस वक्त एंजियोप्लास्टी के हवाले से मैं एक और बात कहना चाहूँगा जो कि अक्सर लोग इस चीज़ को रियलाइज़ नहीं करते. एज इंटरनेशनल कार्डियोलॉजिस्ट वी डू दिस डे इन एंड डे आउट, लेकिन याद रखें कि मोस्ट ऑफ द एंजियोप्लास्टीज जो है ना वो प्रोग्नोस्टिक बेनिफिट नहीं है. इट्स ए सिम्टोमेटिक रिलीफ मोस्ट ऑफ द टाइम. और सिम्टोमेटिक रिलीफ अगर पेशेंट मेडिकेशन के बावजूद उसका सिम्टम हो रहा है, देन वी शुड कंसिडर इट. नॉट एवरीवन शुड. अगर आपने वो ऑक्यूलोस्टेनोटिक रिफ्लेक्स को आपने जो है ना वो रेजिस्ट करना है कि ब्लॉकेज देखी खोलने की जरूरत है. नॉट एवरी ब्लॉकेज नीड्स टू बी फिक्स. पेशेंट इज कंप्लीटली एसिम्प्टोमेटिक, एबल टू परफॉर्म ऑल हिज एक्टिविटीज, और अगर लेफ्ट मेन या प्रॉक्सिमल एलईडी लीजन नहीं है तो दैट इज एज गुड एज एंजियोप्लास्टी और सर्जरी. एंड आई हैव सो मेनी पेशेंट जो इस तरह करते हैं. तो प्लीज ट्राई टू रेजिस्ट दैट ऑक्यूलोस्टेनोटिक रिफ्लेक्स, दैट एवरी आर्टरी नीड्स टू बी ओपन अप. तो इसमें हम फर्स्ट डे में ऑल बेसिक्स कवर करेंगे, एंड आई कैन अश्योर यू दैट इफ यू अटेंड दैट यू विल नो एवरीथिंग बेसिक्स अबाउट इंटरनेशनल कार्डियोलॉजी, एंड दिस इज वेरी इंपॉर्टेंट फॉर ऑल इंटरनेशनल ट्रेनीज. बाकी जो मेन कॉन्फ्रेंस है फर्स्ट सेकंड एंड थर्ड डे, उसमें एक तो मेन हॉल में इट्स गोइंग टू बी ऑल डे बेसिकली लाइव केसेस। हमारा इस दफा थीम ये है कि वी आर एक्चुअली ट्राइंग टू अवॉइड एनी लेक्चर्स और टॉक्स एज सच, क्योंकि वो ज्यादातर होता है कि एक खड़ा शख्स बातें कर रहा होता है, बाकी लोग प्रॉब्ली वो 15-20 मिनट बोले जा रहा है, सो रहे होते हैं, याद नहीं। हमने इस दफा प्रैक्टिकल चीजें रखी हैं, जितनी भी हैं केस बेस्ड डिस्कशंस हैं, प्रैक्टिकल लाइव केसेस हैं, बाइफर्केशन पे केस प्रेजेंट होगा, उसके अंदर हमने लर्निंग सेशंस रखे हैं। कुछ आप में से यूरो पीसीआर में गए होंगे, वहां पे एक केस दिखाया जाता है, इसी तरह हम भी इस तरह कर रहे हैं, केस हिस्ट्री होगी, वो केस प्रेजेंट किया जाएगा। देन वी विल हैव ए वेरी क्लोज इंटरेक्टिव डिस्कशन होगी, किस तरह करना चाहिए, कौन सी टेक्निक करनी चाहिए, क्या उसके लिए एविडेंस है। सबके डिस्कशंस के बाद फिर उसने कैसे किया और क्यों किया उसके बारे में बात की जाएगी। तो इसी तरह के सीटीओ के बारे में हो गया, बाइफर्केशन हो गया, लेफ्ट मेन हो गया, जो कि इंपॉर्टेंट चीजें हैं एज ए इंटरनेशनल कार्डियोलॉजिस्ट, तो विल बी हैविंग दैट लर्निंग सेशंस एज वेल। सिमिलरली वी आर गोइंग टू हैव बेसिकली ट्रेनिंग विलेज, जिसमें के वर्कशॉप्स होंगी, उसमें जो है ट्रांससेप्टल पंक्चर, वेल्वुलोप्लास्टी का सारा इक्विपमेंट होगा, कुछ बेसिक टॉक्स होंगी, फिर हैंड्स ऑन एक्सपीरियंस होगा। सिमिलरली टेवी पे इस तरह का है, इमेजिंग जो है इंट्रावेस्कुलर अल्ट्रासाउंड हो गया, आईएफआर, एफएफआर, वो सारा वहाँ पे सेटअप होगा। इनिशियल बेसिक टॉक एक दो रख के उसके बाद जो है वो प्रैक्टिकल जो है वो हैंड्स ऑन एक्सपीरियंस होगा। तो 4-5 इस तरह की वर्कशॉप हैं, लर्निंग सेशंस हैं। मेन हॉल में जो है वो लाइव केसेस चल रहे होंगे, और लाइव केसेस में भी इसी तरह से डिस्कशन होगी। सो इट्स गोइंग टू बी प्रैक्टिकल सेशन, एंड आई कैन अश्योर यू कि जो भी आप में से वो जाके अटेंड करते हैं 2-3 दिन की या 3 दिन की जो वर्कशॉप है, यू विल कम आउट ऑफ दैट वर्कशॉप। और हमारा मेन गोल जो है ना वो एकेडमिक्स है। फैन फेयर हमने जो है वो सारी चीजें उसमें से वो निकाली हुई हैं, जिन लोगों ने अटेंड किया उनको पता है कि हमारा फोकस जो है, और ज्यादातर लोग हमारे हॉल्स में बैठे हुए होते हैं, वो बाहर कम घूम रहे होते हैं, और अल्हम्दुलिल्लाह जो इंटरनेशनल फैकल्टी भी यहाँ पे आती रही है, दे हैव रियली लाइक द प्रोग्राम, एंड दैट्स व्हाई वी आर नाउ इंटरनेशनल पार्टनर्स विद देम। सो आई वुड लाइक टू इनवाइट ऑल ऑफ यू। और लास्टली जो कॉन्फ्रेंस की एक मेजर चीज है, हमने काफी दिनों से, आई डोंट नो कितने लोगों को पता चला है कि लाइव के केस सबमिशन जो है ना, केस प्रेजेंटेशन, फेलोज केस कॉर्नर हमने रखा हुआ है, जो कि तीनों दिन जो है वो डिफरेंट टाइम्स पे 1-1, 2-2 घंटे के सेशन होंगे, जिसमें फेलोज इस तरह के केसेस जो है वो प्रेजेंट कर रहे होंगे। एक तो हम चाहते हैं कि दे लर्न टू प्रेजेंट, स्पेशली ट्रेनीज जो हैं, और दूसरा उस पर फिर डिस्कशंस भी होंगी। तो 30th जो है वो जून लास्ट डेट थी। अगर फिर भी किसी का कोई बहुत ही इंटरेस्टिंग केस हो तो वी कैन लुक इनटू इट। वी हैव ऑलरेडी रिसीव्ड ऑलमोस्ट 120 सबमिशंस, तो उसमें से ऑब्वियसली केसेस एक कमेटी सेलेक्ट करेगी, प्रेजेंट होंगी। फर्स्ट विनर को जो है 1 लाख रुपया, सेकंड विनर को 75,000 और थर्ड को जो है 50,000 दिया जाएगा। तो प्राइजेस भी हैं, तो आई थिंक वी शुड डेफिनेटली ट्राई टू सबमिट द केसेस। तो आई होप कि दैट इज गोइंग टू बी रियली आई थिंक एजुकेशनल, एंड आई इनवाइट ऑल ऑफ यू टू दिस टाइम इट्स गोइंग टू बी इन इस्लामाबाद। तो 11 से 14 अगस्त तक है इंशाल्लाह। 14 अगस्त को संडे को दोपहर को खत्म हो जाएगा। 11 को जो है ये फेलोज और नर्सिंग है, और मेन जो है बेसिकली 2.5 डे सेशंस होंगे, और ऑल प्रैक्टिकल लर्निंग, नॉट जस्ट के एक खड़ा हुआ बोले जा रहा है और लेक्चर दिए जा रहा है, ऐसा नहीं होगा इंशाल्लाह। तो एक तो ये था। दूसरा, मैं ब्रीफली बात हुई थी शुरू में क्रॉप के हवाले से, कार्डिक रजिस्ट्री ऑफ पाकिस्तान जो है अल्हम्दुलिल्लाह इस वक्त 125 कैथ लैब्स ऑल ओवर पाकिस्तान हैज रजिस्टर्ड, एंड दे हैव स्टार्टेड सबमिटिंग द डेटा। डॉक्टर फैसल जो कह रहे थे कि जी नेक्स्ट ईयर, इसी साल ही अब तक हमारे पास 30,000 पेशेंट्स का डाटा जो है ऑनलाइन आ गया है। तो यू कैन इमेजिन कि अगर 30,000 पेशेंट्स का डाटा अभी रिसेंटली शुरू हुई है, और उसमें जो है अगर almost 300 to 400 variables, what can you do? There's so much opportunities for all of you. इसके लिए हम आगे चल के आप लोगों को बताएंगे। अगर कोई रिसर्च करना चाहता है किसी पर्टिकुलर टॉपिक पे, और आपके पास कोई भी जो आइडिया है, उस आइडिया को आप लिख के जो है हमारी स्टीयरिंग कमेटी है उसको भेजेंगे, and then you can use that data online to basically do that kind of research. So it's going to be a huge resource. What I want to tell, although I know a few people are here, but those who are involved in that, they need to make sure they submit all the data. Sindh Healthcare Commission has recently, they have been visiting the cath labs, and now they are going to go and specifically look for के कौन सी लैब जो है डेटा एंटर कर रही हैं और कौन सी नहीं कर रही हैं। जो नहीं करेंगे तो उनको जो है बेसिकली वो उनका अगेन कैथ लैब का जो है वो लाइसेंस जो है वो खत्म कर दिया जाएगा। सो दे आर गोइंग टू रिव्यू दैट अगेन। एक तो ये चीज़ है, और दूसरी इंपॉर्टेंट चीज़ यही है अनफॉर्चुनेटली कि डेटा एंट्री की जो इंटेग्रिटी है, you see, जितना भी डाटा एंटर हो रहा है ये नेमलेस है, किसी को ब्लेम करने के लिए नहीं है. अगेन वी वांट टू सी हाउ थिंग्स आर हैपनिंग. अनफॉर्चुनेटली अभी तक जो लोग एंटर कर रहे हैं वो इस बात से डरते हैं कि जी मोर्टेलिटी एंटर कर दी तो हमारा हो जाएगा, जी मोर्टेलिटी होगी. और उसकी वजह से कुछ लैब्स ऐसी हैं जिन्होंने चाहे तो 3000 केसेस कर दिए हैं और एक मोर्टेलिटी हुई है, विच इज नॉट पॉसिबल. दैट इज मतलब वो सही नहीं है. तो आई थिंक इसमें ऑनेस्टी से, ईमानदारी से काम लेके कोशिश करें, डाटा एंटर करें. किसी को इस पे पनिश नहीं किया जाएगा, कहीं ये रिपोर्ट नहीं होगा. जो भी आपका डेटा है वो सिर्फ आप एक्सेस कर सकते हैं और कोई नहीं कर सकता. अगर और कोई करेगा भी किसी स्टडी के लिए तो ऊपर से तमाम आइडेंटिफिकेशन सब जो है वो हटा दी जाती है. तो दिस इज अगेन गोइंग टू बी वेरी हेल्पफुल फॉर ऑल दोज हु आर इंटरेस्टेड इन रिसर्च. अनफॉर्चुनेटली वी आर लैकिंग बिहाइंड ए लॉट ऑन रिसर्च. तो इसके लिए आई थिंक दिस इज गोइंग टू बी ए ह्यूज रिसोर्स. जो आप लोगों को सीपीएसपी के लिए पेपर लिखने होते हैं या वैसे अगेन प्रमोशन के लिए भी आपको पेपर लिखने होते हैं, तो अगर आप अच्छे आइडियाज के साथ आएंगे तो यू कैन यूज दिस डाटा टू बेसिकली डू द रिसर्च. थैंक यू.
आपसे कहा था 2-3 लाइन पढ़ दे, आपने नॉवल पढ़ दी. अच्छा जी, हमेशा याद रखें, लोकस प्रेवेंटियोनी मेल और क्वाम रेमेडियम. मुझे भी आती है लैटिन. आपने कुछ पढ़ा था लैटिन? आपने ये तो बताया नहीं कि आपकी जो ट्रेनिंग विलेज है उसमें साग भी और मकई की रोटी मिलेगी. विलेज है, ठीक है जी. अब बैड न्यूज ये है कि लंच खत्म हो गया है. अब 3 बजे तक होता है. मैं इसी पे आने लगा था कि अब हम एक और जगह जा रहे हैं. डॉक्टर बशीर इज फुटिंग द बिल. तो आप लोगों ने घर समझ के खाना खाना है, ठीक है? 2 रोटियां खाते हैं, 4 खाएं. वो कौन थे जो कहते हैं कि 1 प्याली ना पिए, आधी प्याली पिए चाय की? उसका बिल्कुल उल्टा करना है. थैंक यू ऑल फॉर कमिंग. If we can just have a group photo ji.